Dr. Patrick Healy is a professor of surgery and chief of transplantation at Seattle Children's Hospital. He is one of the few surgeons in the nation trained in both pediatric surgery and transplantation. And in addition to leading our successful transplant program, he currently serves on the UNOS Board of Directors and the Pediatric Task Force of the American Society of Transplant Surgeons. So we're really excited to have him presenting for us this morning, and welcome, Dr. Patrick Healy. Thank you.
Well, thank you, Suzanne, and very excited to be here. Thank you. What I'd like to do this morning is take a look and take all of you through in a little different view of pediatric liver transplantation, look at equity. Objectives today would be to describe the current state and framework of liver transplantation in the United States. And this is really for just to provide some context. This is the world that all the transplant programs live in, and definitely impact and shape what the experience is for our children who are also in that world. We want to examine the process for an individual patient with organ failure as they move through the system from referral to liver transplant, and then discuss specific challenges for children that may exist. And then finally, there's a project that we did here, looking at our own experience and performance caring for children who need a liver transplant, focusing on the equity through the process as the kids go through the process. I have nothing to disclose except that I advocate for children to receive the best opportunity for a liver transplant if they're in need, as they're in need. So 2021 was a huge year for transplant, and over 40,000 transplants were performed in the United States in 2021. That's the first time that threshold has ever been reached. It's also the 11th year in a row that deceased donor transplantation increased. And what's pretty remarkable is that this 40,000 threshold actually was over 41,000 actual transplants was achieved during the pandemic. And there was a 2 to 3 month period of time in the spring where the donation was decreased and then had to ramp up. Not quite so much as happened in 2020, but still remarkable that we've hit this threshold. So in order to get a transplant, though, how do we get to 40,000 transplants? Well, you need to be on a waiting list to receive a transplant. And this is what the waiting list currently looks like. This is a list that was pulled on the last day of February, so just a little over a week ago. And one of the great things about transplant is data is available and current on very, very detailed data, but descriptive, broad. This is the waiting list by organ and age. And what you can see is there's over 116,500 individual people waiting for an organ transplant in the United States on this day. This goes down to, you see, 97,000 waiting for a kidney transplant, 11,600 waiting for a liver transplant. Children, and they're defined as less than 18 years old, only represent 2,029 patients out of 116,000. It's only 1.7% of the waiting list. So right away, you can see that the children really need to have support in order to get opportunities to access donor organs, because if they just had to wait in line, there would be, almost they'd be waiting 1 out of every 100 offers that comes around would come to a child, and that's not fair, not acceptable. Of the children, if you look at just the liver list, there's just about 355 patients on the list at this time, which makes up about 3% of the overall liver waiting list. This number, interestingly, has been pretty stable over the years. The diagnoses that are transplanted for kids are congenital and acute liver failure, liver tumors. The incidence of those conditions are fairly stable over time. And so the number of kids waiting is typically in the 300 to 500 range. So how do we actually balance the need? How do you provide 40,000 transplants when there's over 100,000 people waiting? There's not enough organs available. So this balancing, trying to balance justice on the one hand versus utility. Justice being the need for treating the sickest patient first, utility trying to make the best resource, the best use and longest success from a scarce resource. So this space is actually quite familiar to all of us who live in the transplant world, and trying to get transplant where we're trying to advocate for getting our kids transplanted, yet also be a good steward for the scarce resource. So how do you balance this? We need a structure. The structure is actually called the Organ Procurement Transplantation Network. And the result is you need to structure the result to create rules and regulations that are going to hopefully produce the result that you need. There's law that was used to create it. There are membership criteria, policies, and procedures. One of the big important elements of this is that there's transparency and currency in reporting outcomes. As I mentioned, transplant outcomes are publicly available. This is information that is required to be publicly reported and within 6 months of time. So twice a year, there is published transplant program reports that detail the activities. And some of the data that I'll present today comes from our center report. There's also regulatory oversight, and then through the process of reviewing outcomes and policy and working through committees, policies can be changed and new policies developed that recognize inequities or ineffective policies. So this is what our current structure in the United States looks like at the moment. UNOS, which is the United Network for Organ Sharing, that's the company that actually has a contract with HRSA to run the organ procurement and transplant network. So the country is divided into 11 regions, and we are currently in regions, we are not just currently, we are in region 6, which includes the Northwest, plus Alaska and Hawaii. So our region is geographically very big and broad, and yet much of it is sparsely populated. So our population density is very low compared to other regions. Within the there's regulatory oversight, as I mentioned, and the members of the OPTN include transplant hospitals, which is Seattle Children's is a member, and organ procurement organizations. Our OPO is Life Center Northwest, and there are 58 OPOs in the country, and they are also contracted to provide organ donation services and care for organ donors, and also to run the match program, which allocates organs from donors to recipients waiting. Tissue typing labs are the third element of the membership. So here's the process. So this is a general sequence for how do you get a transplant. Patient has organ failure. They need to be referred to a transplant center. There's about 200 130 or so transplant centers in the country for various organs. At the center, they're evaluated, their medical, clinical, their history, social history, risk factors are assessed. And then they undergo this evaluation, and then typically there's a transplant committee that will evaluate look at all the evaluation and really make a decision if the patient is a suitable candidate to be on a waiting list. Now, that's a complicated and variable process in different centers, and the structure may be the same, but there's really a lot of variability on how that process works. And it can be subjective in some elements, but patients are either accepted or not accepted onto the waiting list. We're fortunate that in pediatrics, actually, most of the children, there are very few absolute contraindications to placement on the waiting list. If somebody has a medical issue or they need some psychosocial or family support or financial support, our approach is, the approach in pediatrics has been to try to provide that support, to try to find a way to provide that support, and instead of denying someone an opportunity to be on the waiting list. So it looks like a pretty straightforward process. To get placed on the waiting list, you wait for a while, and then while you're waiting, organs may be offered to your center, and you wait for a match, and then you get called in for a liver transplant. But I just want to take a little side view here. When you look at that process, I mean, what do you see? What do you see? So do you see the vase, or do you see something else? And this question comes up. I actually ask this question a lot when in different situations. I can just picture or see all my fellows I've worked with over the years just rolling their eyes right now, because trying to determine, like, what are you seeing? What are we seeing? It's really important. So well, it depends what you see. It depends on what are you looking at? What catches your attention? What are you looking for? And these are all, it's this perspective actually that is really important if you really want to look at equity. Because if you're not looking for it, it's very easy to not see it. And so let's take a look at our pathway again here. So when you look at this now, is this a pathway to transplant or actually a gateway? Patients present with organ failure, and they get referred to a transplant program, but it's important to ask, who is referred? Well, who isn't referred? And they're evaluated, who gets accepted and who doesn't. Placed on the waiting list, who gets an offer and gets transplanted, and who dies on the waiting list? As it turns out, right now, about 17 people per day in the United States are dying waiting for an organ transplant. And then once you get an opportunity for transplant, how are outcomes compared? Are they equal across the country? Does where you get a transplant make a difference? So what I hope to do today is to walk through this transplant process and spend a little time looking at each step, and then also try to provide some examples of what is going on and what some of the policies and some of the practices that are happening and in play that impact how patients actually progress through the system. So let's start with just the transplant referral process. Who's referred and who isn't? So as I showed you in the beginning, the transplant wait list, 116,000 patients waiting for an organ transplant. This is data from the National ESRD, end-stage renal disease census data from December of 2021. This captures everybody in the U.S. who has renal failure and is on dialysis. There's 7,800 dialysis centers in the United States and 228 transplant centers. There's actually 523,425 patients waiting for that, patients that are on dialysis. And yet there's 97,000 patients on the kidney transplant waiting list in the country. So as impressive a number as 97,000 people waiting, that's only 18.6% of the patients on dialysis already. And that doesn't include the number of patients who are not yet on dialysis, but probably meet criteria to receive a transplant. So the issue of access to transplant centers, access to the list, referral from dialysis centers is a huge issue. And we're fortunate that we have a dialysis center. We have a great nephrology program. We're actually the only dialysis center for children in the Northwest. And any child with renal failure is probably going to find their way to our nephrology team in some way, shape, or fashion. So I think in our situation, the kids may be better off than adults here because they do get referred to pediatric centers most of the time. But this is a remarkable and striking statistic that less than 20% of patients with renal failure actually get referred to a transplant program. Another, and then how do you tell when how do you measure renal function? Well, the estimated glomerular filtration rate is kind of the marker. And when renal function declines, there's calculations, and if your GFR reaches below a certain number, then there are guidelines to refer to transplant centers. There are also guidelines to criteria for being on the waiting list. So your creatinine clearance or your GFR needs to be below a certain level in order to be listed. One of the things that's come to light this year is actually there's an equation which is called the chronic kidney disease epidemiology, that came from the chronic kidney disease epidemiology collaboration, that has 4 factors in it. And race is actually one of the factors in this calculation. I mean, this is something that I didn't have any idea about this detail of the formula until a year or so ago. But back in the late 90s, there was some research that basically concluded that Black patients had higher levels of creatinine at equivalent levels of renal function to a lower creatinine. So at that time, formulas were made, and it just became incorporated into the assessment. So basically and I'm just going to take you through this a little bit right now. So it's called the race coefficient. And basically this graph here shows the difference between a measured GFR, which is across the bottom line here. These on the x-axis are measured GFRs as measured by a nuclear medicine scan or something like that, and the calculated number using the eGFR calculator. And each circle represents, and the height above this represents the delta between what the circle is, or what the calculated number is, and what the actual measured number is. And what you can see is in each of these cases, adding the race factor improved your GFR. And so it improved the calculation of the estimated GFR. So at a given creatinine level, and I'll take you through an example of this. So at a given creatinine level, Black individual would have what looked like a better measured GFR than someone who didn't have the the number, that coefficient applied. And why is that important? Well, actually, it's a low GFR, a low creatinine clearance that is a criteria for referral for either transplant center evaluation or listing on the waiting list. This blue line here is the standard. It's an estimated GFR of 30, which is a general recommendation where you should be referred to a transplant center for evaluation, or to a nephrologist for evaluation for renal failure. And then 20 is the absolute number that you need to be below 20 in order to be listed if you're not on dialysis. So what are consequences of this? So studies have shown that the black race variable may increase the GFR calculation by as much as 16%, even if everything else in the equation remains equal. So that'll delay referral for transplant. It'll delay initiation of getting on the waiting list, and waiting time is a very important factor in who gets transplanted. And it also may impede timely management of chronic kidney disease. It also obviously and clearly exacerbates existing disparities. Here's an example. So this is just walking through these. This is doing the calculation for two individuals. Everything's identical. So 60-year-old male, serum creatinine 3.3, same thing. And in one case, the black race is no, the other is yes. And the GFR calculated is 23 for the black individual, 19 for the other. Now 19 gets you on the waiting list, 23 does not. So it's clearly inequitable. This is actually the timely, this policy or this calculator is actually currently being reviewed. And at UNOS right now in this cycle, there's a proposal to eliminate using any calculator that incorporates a black race coefficient or any coefficient that specifically singles out any racial or ethnic group. So there are other calculators that don't include race, and there are also other factors that can be used to be included that are not race-based and maybe just as accurate. So with this, so removing the black race coefficient will result in 16% increase in the total number of black patients classified as having chronic kidney disease, and 3.1% will be reclassified and end up with a GFR that meets criteria for listing for transplant. Patients the patients reaching patients who reach the transplant threshold an average of 1.9 years earlier just by the impact of this coefficient. So who is placed on the waiting list? Who's accepted? Who isn't? I mean, right there, we just finished talking about the calculator for kidney transplant. How does that? How about other? What does the waiting list look like? So, if you look at the waiting list for liver transplant, there's 11,400 patients on the waiting list. 2/3 of them are white, 7% are black, 20% Hispanic, and 5% Asian. This has been a pretty stable number over the years, though the overall number is increasing. On the pediatric list, this is what the pediatric wait list looks like. About half of the patients are white. 20 to 25% Hispanic, and 15% black. Asian and other are less than 10%. this is our waiting list right here. And this comes from our center-specific report. The Scientific Registry of Transplant Recipients is the agency that reports transplant center and OPO performance and outcomes twice a year. So this report was released in January this year, and this is a snapshot of our waiting list on June 30th last summer. So at that time, and has two components to it. On the right-hand side, this is our whole list that exists. There was 40% white, 20% African American, 20% Hispanic, 13% Asian. If you look just in the last year before this, the most recently added, a third of the patients that we added to the list in the last year were Hispanic, 20% or almost a quarter African American, and the percentage of white patients was less than 30% in this given year. We added 22 patients to the waiting list during this year from 2020 to 2021. On the right-hand side, this is who we transplanted in that same time period, and our half of the patients that we transplanted, so 6 of the 12 transplants in this report cohort were Hispanic, and 2 African American, and the remainder white or other. In our program here, the other is and I'll go through this later, but the other is primarily Native American or Pacific Islander, Hawaiian, and then there is also about 20% of our program is more than one self-identifies more than one race. So once you're on the waiting list, who receives an offer and who is dying? Oops, sorry about that. So pediatric waitlist mortality is really the one of the problems. Right now, it's this is from the UNOS, the OPTN annual report data, and this is the death rate, the number of deaths per 100 waitlist years, and right now it's between 7 and 8 per year. Now, if you look at on the chart on the right, the ages of the patients at risk, the small babies, the youngest patients have the highest death rate on the waiting list. At it's in the 12 to 13 per 100 waitlist years. The others are around 5. So looking at this UNOS data, 76 children died last year waiting for one organ or another. The biggest, the most common organs where patients are dying would be heart transplant or liver transplant, so that they make up the majority of the children that don't survive while they're waiting for transplant. But you can see here, there are almost 6,000 deaths on the waiting list. And as I mentioned earlier, it's about 17 people every day are dying while they're waiting for an organ. If you look at the transplant mortality of children on the waiting list by race, you can see that, well, maybe 10 plus years ago, it was quite higher for other races and Asians. It's quite variable, but most have settled into the 10, 6 to 10 deaths per 100 waitlist years. So, and the other still is on the higher end of the cohort. It's been encouraging to see that it's come down, but it's discouraging to see that it's not continuing to get lower. it's been in the same general range for the last 8 or so years, 8 to 10 years. So looking at liver transplants, so patients get a liver, they've been on the waiting list, they get a call, and they're coming in for a transplant. Does it matter what other factors can impact their outcomes? Well, this is a study from a few years ago now. It was published in 2015, but looking at the likelihood of getting a transplant and the outcomes based on the size and activity level of your program. Now, this study was done using national data from the same source that I've been pulling a lot of this data. So this is UNOS data, and in the graph on the left here, each of these dots is a transplant center, and you can see the number of centers, then how many transplants per year, as they're distributed here. There's a number of centers that do less than they only do a handful of transplants a year, and then as you get across the chart to the right, you can see that at this time, really the number of centers that do more than 20 liver transplants per year is actually quite few. And we live in the 15 range, so 15 to mid 16 range. Last year we were a little lower than that, but that's where we typically are. So, but the majority of programs in the country do fewer liver transplants than we do. So so activity, how does that impact it? This center graph is a Kaplan-Meier curve showing the likelihood to get a transplant. And so kids are waiting in these low volume centers. You wait longer, you're less likely to get a transplant. And this is a statistically significant difference. When you get transplanted, these kids in the chart on the right, you can see that in the patients that are in the centers that do less than 5 transplants per year, outcomes are worse. And the others are all pretty equivalent. The group with the highest here, although this is not statistically different here between the upper groups, the highest group is the ones that do around 15 per year. So it does seem to matter. And so another factor to that we looked at here was, what about living donor liver transplant? So here's data from on the left, living data about outcomes, and outcomes are very good with living donor transplant. In children, if you look at this graph from the annual report, outcomes are better if you can have a living donor compared to a deceased donor. Both are good. They're both on this graph up to 5 years. You still have almost just around 90% survival, but there is a clear difference between living donor and deceased donor. In the chart on the right, this is the actual number this is the number of living donors broken down by ethnicity. And apologize that the years got cut off, but this column right here with 568 transplants, this is 2021. And of those 568, 442 of them were performed in white recipients. There were, and you can see the numbers. Hispanic recipients transplants was less than 100. Black recipients was less than 20. And this is for the current year, 2022. So living donor, while it does improve the outcomes, it is not equitably distributed across all race and ethnicities. That's sort of for general context and setting. I want to next go through a little review that we did with our program, just to look at how are we performing as we walk through the process. And in order to do that, I wanted to focus on biliary atresia. So biliary atresia, I think most of us here are familiar with this condition. This is the diagnosis here. infants present with jaundice, usually in the first month or two of life. And we make the diagnosis by cholangiogram. So this on the left is an operative cholangiogram. We've put a catheter here and into a very small gallbladder. In this particular cholangiogram, you can see a very fine little duct that runs off and it goes into the intestine. And you might look at that and say, this looks great, except that none of this contrast goes back up into the liver. And that's the diagnosis of biliary atresia. There's a problem with the ducts draining the liver. So the diagnosis is biliary atresia, but the real problem is this is shown in this liver biopsy. This is a biopsy and done at the same time as the cholangiogram. And what we see is abnormal ducts. We see fibrosis. We see duct proliferation. So these are all signs for duct obstruction. And this is really the liver disease is the problem with biliary atresia, even though we do a biliary drainage operation for them. The operation is called a Kasai procedure. And unfortunately, most people refer to it as the failed Kasai procedure. So, but it really, if you think about it, providing drainage to the liver, it's you have to be able to get it before there's too much damage in the liver for it to be able to provide long-term improvement to the liver itself. So as I mentioned, biliary atresia is a cholestatic liver disease. It progresses. It's the most common indication for transplant in children. And after transplant, we have excellent graft and patient survival. So our review looked at 10 years of our experience transplanting of kids with biliary atresia who had a transplant. That was 55 children. We looked at going through that process. We looked at the time intervals from evaluation to listing, to being on the wait list, to getting a transplant. And then once transplanted, what was the length of stay? And also try to get an idea of how sick were they when they got transplanted. And we wanted to look at this through a ethnicity and language lens. Here's this process again, and I'll just go through the data that from our study, and it measures the time between each of these steps and also the length of stay in the transplant admission. So when we look, I'm sorry, this is a busy slide, but the data is reported here as this is days. So this is median number of days because the ranges are wide and the numbers are small. So we use median. And so all patients are 55 biliary atresia patients in the last 10 years that were transplanted. And and the median evaluation to the time from referral to evaluation on average was, or excuse me, a median was 17 days with a very wide range. In general, once they were discussed and reviewed at our selection conference, they were placed on a waiting list within 2 days, although that varied as well. And in some situations, it was quite long. And then once they're on the waiting list, how long did they wait? On average, it was around 4 months. A couple of them waited years because they were very stable, and that is shown out in some later data. And then once they were transplanted, the median length of stay was 20 days. Breaks down to about 40% of the group was white children, 20% Hispanic, 20% identified with 2 or more ethnic racial groups, and then the other 20% were Black, Asian, or other. And as I mentioned earlier, other, it really includes or is made up of Native American and Pacific Islander, Hawaiian patients. So if we look at specific groups now by ethnicity, we see that there's fairly similar time. The Hispanic time for evaluation for Hispanic patients was shorter, and the numbers being so small, the statistics um, are not showing difference, but the it looks like 6 days shorter than for white patients. Their selection time was shorter. One thing that did stand out of this is that the time from selection conference to wait list placement was a week longer in these few Black patients, and the waiting times here um, were a month longer on median in this group compared to Hispanic or white patients. And this is, like I said, just an observation. There isn't any statistical um, separation here. Hispanic patients stayed in the hospital a little longer. They had a 10-day longer median length of stay. And interestingly, when you look at patients with in the other group, as I mentioned, those are the ones with the longest time of waiting, but they also had the shortest hospital stay. And as I'll show in another slide, um, clinically they were the most stable and healthy group. By language, we looked at it here, English and Spanish. Um, the majority were English speakers, and but the Spanish speaking families actually had a quicker evaluation, and they were on the waiting list shorter. Now, but their length of stay was longer. So putting that together would say that makes us think about how sick were they when they were referred, because they were obviously transplanted faster, sooner, so they must have had a higher acuity. And that's in the next slide. And I apologize, this is very busy because I wanted to get it all on the same slide, but this is a combination of the ethnicity and the language data of groups. One of the things that, so in terms of assessing their clinical status, several patients were delayed and never had a chance for a Kasai. And we saw actually 4 children who presented with chronic liver disease, end-stage liver disease, and had not had a Kasai. And interestingly, none of those 4 were white. And all 4 of these came in since 2019. So all of these patients who did not receive a Kasai, this happened during the pandemic. So raising question of access to just general pediatric care or referral to gastroenterology and hepatology in a timely manner. And fortunately, we were able to transplant all of them, and they're all doing well, but they presented with their first presentation of biliary atresia was with end-stage liver disease. So this is a chart showing kind of severity of illness. The PELT score basically correlates with your risk for 90-day mortality from your liver disease, and it ranges from 0 to 40. And in this case, overall, at listing, we saw a PELT score of 14, and by the time of transplant, it was up to 30. And of the patients who were transplanted, almost half of them, 22, were in the hospital at the time of transplant. So it's clear that this population is getting sicker. And how did that balance? This sort of distribution, 40 to 50% in the hospital, was true across all groups here. So just a summary, I see where I realize we're getting a little short on time here. This is our process in looking at what did we find? So as I mentioned, looking at the late referrals, we saw 4 children who did not have an opportunity for Kasai. All of them were non-white, other racial groups, and those occurred in the last 2 years. The transplant evaluation on average was around 2.5 weeks to accomplish, but it was 1 week longer for those with multiple racial groups. Placement on the list, as I mentioned earlier, and the numbers are very small. It may just be related to one or two patient issues, but or our team, but it's something that merits further look. Um, that it was 1 week longer for Black or other patients. Fortunately and proudly, we had zero biliary atresia deaths on the waiting list. And this is despite or the kids getting progressively sicker and 20% being in the ICU at the time of transplant. So that's we have a great, not just transplant team, but our ICU colleagues, our inpatient teams, um, really do a great job taking care of whatever the issue is that these kids come up with or present with as they're waiting. Overall, clinically, we did not lose any patients in this whole cohort. We had 100% patient survival. There were 3 early graft losses due to artery thrombosis, where they got early retransplant. So we had a 94% 1-year graft survival, 100% patient survival. I will say that one of the patients died a couple years after transplant when they were waiting for a retransplant due to recurrent rejection. That's the only death we've had in biliary atresia patients since 2004. That's a statistic we're particularly proud of. So in conclusion, there are racist policies and practices that exist in the US transplant system, and they result in inequity and disparities in access to transplant, organ allocation, and transplant opportunities. We need to advocate for OPTN policy change and also improve community education to address these inequities and improve timeliness for referrals. We need intention to identify and address inequities in our own care and our processes for evaluation and referral. And we also, as is an effort across the hospital, we need to include equity in our daily work and know how we are actually doing in this way. And last, I just want to say for this last point, one of the things that we have done in transplant, and I apologize but this is our kidney transplant dashboard, but we now have a dashboard that's been built in Tableau that can give us real-time race ethnicity data on how are we doing on each step: referral to listing to transplant to discharge. So looking at by race and ethnicity, and also by preferred language. So keeping this front and center is only going to help us do a better job taking care of all of our patients. So thank you for the opportunity. Welcome any questions.
Thank you so much. There are already several questions in the chat, so I'll get started. And for those of you who continue to have questions or comments, please keep typing away. We'll get to as many as we can. First, from Carol Shepwood, I'm sure I'm pronouncing your name wrong, I'm sorry. Does parent decision-making moving forward influence the numbers?
That's a really good question. I mean, that's a great question because, and it's, it does to a point. I would say that if a parent actually actually does not want to move forward, the outcomes are so good in post-transplant in biliary atresia in particular that that has been considered not in the best interest of the child in some situations, and other decisions or process, even a CPS or court assessment has been used in the past in some situations. It's it's a tricky. Most of the time, the parents it's overwhelming to learn about this problem, but there's no question liver transplant is a big therapy. but it is a incredibly effective and lifelong um, uh, effective therapy. So it really is the standard of care for these patients. So the opportunity to decline is getting less as the outcomes get better.
Thank you. From Ken Feldman, how does living versus cadaver donor affect the biliary atresia transplant statistics?
Thanks, Ken. Good question. Biliary atresia patients, because they are um, there is a fairly kind of predictable progression of disease. It's just you don't know how quickly an individual patient might go. You know that it is progressive, and so it does allow for planning. And biliary atresia babies tend to be the most common recipients of living donor transplants in children. Um, Having said that, the outcomes are in order to get a living donor transplant too, they are generally they can be planned. They're elective. You have the opportunity to do them before the child is really at a end stage hospitalized or even or ICU level care. So I think that the outcomes will improve with living donor. The outcomes with deceased donors are already good, but there are more complications and more issues because of the deceased donor nature.
Thank you. And from Mark Wainwright, very interesting talk. Thank you. Can you comment on what disparities you see on access to ongoing medical care after a liver transplant and any impact this has on outcome or quality of life?
That's a very important question, Mark. And in the evaluation, social work and family support and um, is evaluated, and not as a exclusionary, not from a look to try to exclude anybody, but to try to understand how do they need to be supported. But one of the big issues is, currently right now, Medicare will cover, um, insurance will cover immunosuppression medications for 3 years. And so they need to maintain insurance. They're and they need to children when they're small have parents, so they need to have somebody to take care of them when they get to be adolescent or if they have family uh, support issues and don't have that. Then they can lose access to the medical community, and that does have a negative impact on outcome. The risk for rejection or for even survival is worse if you are not able to maintain the care that mostly because our immune system has such a good memory, and even years later you can develop rejection that can lead to graft failure. So um, I think that access to medical care and we see this in our transition patients when they stay with us until they get to be 18 to 21 years old to transition to an adult program. And that's a very high risk time in their life. Number one, there's lots of changes going on, but number two, changing to a different medical care system, moving away from children's to wherever they move.
Thank you. And from Dr. Cora Bruner, great talk. Can you comment on liver transplant success in the adolescent overdose patients? Great question, Cora.
Well, Cora, thankfully that is really a very small percentage. The question of suicide and or not the question the incidence of suicide of liver transplant and suicide attempts is very, very small. Fortunately, non-transplant treatment for or recovery and support of Tylenol overdose has improved tremendously. So the number of children who actually get transplanted for that indication is pretty small. But having said that, this is a group we worry about, and I don't think it's as good, just off the top of my impression, but I don't have the data right in the front of my head. But I would say that many of these, whatever the situation or the conditions that sort of led the child uh, to this overdose, this transplant has probably not impacted any of those factors. So it requires a lot of support, and I know that there, but it's becoming less and less common that to see these kind of patients. We may evaluate them and work them up and even get them on the list, and while they're being cared for, and then thankfully, as I mentioned, most of them get better without transplant.
Thank you.
Along those lines, I just might add, we see the incidence of overdose and narcotics overdose in particular. This is an increasing percentage of donors. Of these patients have overdose and arrest and significant brain injury, and then become deceased donors. And so much of the donor population that is shifted. It's the sort of historical or typical kind of initial thing that comes to mind is a trauma patient who has had a head injury, and that is not the majority now. The majority of a big proportion of donors have had overdose or have had other um, vascular issue there. I mean, trauma still happens, but trauma regulations, speed limits, helmet safety laws, those have all been effective at decreasing the incidence of critical head injury that would lead to death. So it's really it's really been very interesting social view on social lens from the transplant perspective, just looking at how do people become donors.
Wow. Well, thank you for that perspective. And I'll close. We have about 2 minutes left, so I'll close with this comment from Dr. Richard Sugarman. Thanks for updating our understanding of solid organ transplantation, Pat, and for raising our awareness on these important issues around equity. And from me and everyone here, we really appreciate your expertise, your specific training. We're really, really lucky to have you here and all your hard work. So thank you so much for spending your hour with us. And to our audience, thank you so much for being here. And we'll see everybody next week.